Welcome, everyone, in this webinar today on vaccination. While participants are arriving, I would just like to share some details about the webinar. So this is a listening webinar. You will hear and see presentations. And you can ask questions in the Q&A box, and we will take the questions after the presentations. There's also the chat box you find on your screen. Please, if you wish, please introduce yourself and share messages with us during the webinar. The webinar will be recorded and shared with the registered participants. We will also collect the presentations and make them available on our website. So we'll wait a few more minutes for everyone to arrive to the webinar, and then we'll shortly start. So today, you will hear about vaccination strategies addressing homeless people and case studies on vaccination campaigns that have been delivered to people experiencing homelessness. Our timing is very good, not only because we have already quite a few examples and case studies of vaccination delivered for homeless people, but also it's a good time because this week is dedicated to the immunization week by the WHO, so which is held every year to highlight the importance of vaccines. And this year is focusing on the COVID-19 vaccination as a vital tool to end the pandemic. And main message of this immunization week from the WHO is that no one is safe until everyone is safe, and that of course highlight the importance of equitable access to vaccination, include for all, including the most vulnerable, and highlights also the need to ensure that vaccines are distributed so that they are available and accessible for homeless people. FEANTSA has done some work in this area. We have developed a statement that is available on our website, and it has a list of recommendations on how to improve access and uptake of vaccines for people experiencing homelessness. We have shared this statement with the European Center for Disease Control, and now we are collecting case studies on vaccines deliveries to allow our members to learn from each other and improve their vaccine delivery plans. So this webinar is exactly trying to achieve that today. So we have 7 speakers from 5 different countries to share their vaccination strategies and case studies. Our first speakers are Stéphanie Vandentorren and Jalpa Shah from France. Stéphanie is the coordinator of the Health Inequities Program at the French National Public Health Agency, and she has led several epidemiological investigations related to health crisis and vulnerable populations. She is a medical doctor with a PhD in epidemiology and the certification to supervise PhD students. Jalpa is a project lead for vulnerable populations at the French National Public Health Agency. And during the early months of the COVID-19 crisis, she helped reinforce the new transversal program aimed at strengthening equitable health solutions for underserved populations. She has a bachelor degree in biology and a master in public health with a specialization in epidemiology. Thank you, Jalpa and Stéphanie. The floor is yours.
Stéphanie, we can't hear you, sorry.
Good morning, everybody. We'll present you our work on developing an evidence-based COVID-19 vaccination strategy for people experiencing homeless from the French National Public Health Agency. So we estimate the recent point to around 300,000 people experiencing homeless in France, which including different shelters, temporary or asylum seekers, or different type of shelters. And we know that people experiencing homeless are disproportionately at greater risk of not only infection, but also severe COVID-19 cases because of deleterious physical, psychological, and social consequences of the different protection measures as lockdown and curfew. And there is a specific French context because of saturation of hospital service during the crisis, but also there is no enough accommodation actually for homeless people. And so the aim of our work is a multi-stakeholders knowledge sharing webinar series to share information on evidence-based vaccination strategies and also identify related health and social issues for people experiencing homeless during this prolonged COVID-19 crisis. And we want to guide the implementation of prevention strategies across France. So the vaccination schedule is in France, first of all, is free for everyone and non-mandatory. That's important to precise. And the people living in precarious conditions are only in the step 4 of the vaccination schedule. But some of these individuals receive 1 or more doses during the earlier phases because of comorbidities or because they are elderly people, for example. And there are no estimated of how many people experiences homeless have been vaccinated actually. So the work is based on 2 analyses. First, it's a transfer of knowledge, which is inspired from the Quebec, the Institut National of Public Health in Quebec. And we have to analyze the public needs first, which is secure accommodation, food, service, and mobility. And second, the context analysis, which is very important in France because of the lack of accommodation and the difficulties on the emergency service. And then we define the objectives to identify key factors and 3 methodological steps, which is sharing knowledge and from the different studies, and then influence decision by qualitative interviews on decision makers and actors from the field, and then to improve practice by the webinar. And then my colleague Jalpa will take it from here.
So as Stephanie mentioned, we kind of did a public needs analysis and a context analysis, identified our objective, which was really to identify key factors that influence COVID-19 vaccination for people experiencing homelessness in France. And then our goal is then to adapt our strategy accordingly in real time in terms of how we go about vaccinating this population. So today I'll be focusing specifically on the scoping review that we've already conducted and which I think will be quite useful for all of our colleagues as it was an international scoping review. So in terms of methods, we conducted the review on January 15th. So we went through a bunch of bases, PubMed, Cochrane Library, Epistemologos, and then we completed our review with gray literature that we found on Google and Google Scholar. I'm not going to go through all the different key terms and mesh terms that we use, but the key takeaway here is that we were really focused on hard to reach populations, which of course include people experiencing homelessness. We were interested in all vaccination. We didn't limit it to a specific disease or a specific vaccine, and we were focused specifically on evidence-based findings. In terms of limits, we looked at publications in the last 20 years. We were interested in any studies published in English or French. With respect to COVID-19, we decided that we're going to limit our research to adult populations as the current vaccines are not available for children. And then we were looking specifically at findings from high-income countries. So we started off with about 531 studies that we found and reports, and we ultimately retained 19 sources using the PRISMA extension for scoping reviews. So in terms of inclusion criteria, we were really focused on evaluations of vaccination programs that targeted specifically hard-to-reach populations. So not national vaccination campaigns that were for the general public and then looking at how that impacted the more hard-to-reach populations. And in terms of exclusion criteria, we didn't include studies that were just protocols. We excluded studies that didn't look at hard-to-reach populations, studies that were not applicable to the French context. So as Stephanie mentioned, vaccination is free in France. For any studies that weren't evaluating vaccination programs, we didn't include them. Self-reported vaccination as an outcome was also excluded, and then all studies with insufficient power for quantitative analyses were excluded. So I think this is the more interesting part for all of us. What did we find? And actually, there were a very limited number of evidence-based studies on vaccination strategies that target hard-to-reach populations, including people experiencing homelessness, and that were applicable to the French context where vaccination is free. What was especially interesting for us and definitely pertinent to the current COVID-19 crisis is that factors that influence vaccination for hard-to-reach populations really vary based on the outcome. So whether we're talking about a single dose or a multiple dose vaccine, because that means that our outcome is different, whether we're looking at vaccine initiation or we're looking at vaccine completion. So when we think of vaccine initiation, for hard-to-reach populations, there were a series of influencing factors and competing factors that came from our study. At an individual level, awareness of the severity of the disease and concern about getting the disease definitely came into play. For pregnant women and diabetics, doctors' recommendations were significantly related to initiation of vaccination. And then in terms of contextual factors, and this is what we found especially interesting, things like immediate availability of the vaccine following screening. So here we're looking more at diseases like hepatitis A and B, where we tend to screen before we vaccinate. On-site vaccination following screening. So again, contextually having easy access to vaccination. Again, contextual factors like distance to the vaccination clinic, waiting time at the clinic, all played into influencing vaccine initiation for these populations. And then finally, social mobilization and outreach programs definitely played a key role in influencing vaccine initiation. When we think of competing factors, obviously pressing material needs, if we're thinking of Maslow's hierarchy of needs, things like food, water, and shelter consistently outcompeted vaccine initiation. So when these factors were of greater importance, obviously vaccine initiation wasn't put into play. And then when we think of multiple dose vaccines, so if we're thinking of COVID-19, where we do have vaccines that involve 2 doses, vaccine completion was influenced by a series of different factors. So at an individual level, poor self-related health scores were significantly associated with vaccine completion. Again, on a more contextual level, things like receiving screening results definitely helped achieve vaccine completion. Having accelerated vaccination schedules, so 2 months versus 6 months for certain hepatitis vaccines. having nurse case management for 6-month hepatitis A and B vaccination, and then convenience, so specifically associating vaccination clinics with other services. So this was for injection drug users and having the availability of needle exchange plus vaccination at a single site. And then finally, and these were more studies from the US, having monetary incentives. So giving monthly monetary incentives actually outcompeted weekly contact outreach, with an outreach worker. So we found that monetary incentives played a key role in vaccine completion. And then for hard to reach populations, competing factors that worked against vaccine completion were either threats of eviction or actual eviction or expulsion from where they were living. And so this actually brought up a number of ethical considerations for us as we develop our vaccination strategy for hard to reach populations and for people experiencing homelessness. As I mentioned, should we be thinking of single vaccines or single dose vaccines, or should we be aiming more for multiple dose vaccines for these populations? Will there be screening prior to vaccination to determine current or previous infection, given ongoing vaccine shortages, but also recent studies from Israel that show that with Pfizer, for example, a single dose was highly effective for individuals who had already been exposed to COVID-19. Should we be skipping screening completely, given the high exposure and transmission observed amongst people experiencing homelessness in 2020 during the first wave of COVID-19 in France? And so should we just assume previous exposure and give them one dose? Should we be prioritizing a specific vaccine for these populations? So with vaccines with higher efficacy in terms of reducing transmission. And then in terms of next steps, we're definitely interested in conducting interviews and speaking to experts who've already implemented COVID-19 vaccination for people experiencing homelessness as a national priority in other European countries. As unfortunately with our review, not a single study was on COVID-19. They were all on previous epidemics. So that was quite quick, but we'd be happy to take any questions at the end of all the presentations. And I think I'll leave you there.
Thank you very much, Stéphanie and Jalpa. This was a very concise and quick presentation, but very important and highlights. Very important that you highlighted what we could learn from previous vaccination campaigns for homeless people, and what can we take away from that, especially in how to reach homeless people. So I think it was a great presentation. Thank you very much, and it would be great to also see this scoping review if you have it accessible. And you raised a lot of important questions that I think the others will also might respond to them and will reflect on, and we can continue the exchange in the question and answer sessions. And now our next presenters, but I kindly ask Jalpa to stop sharing the screen. Okay, that's great, thank you. So our next presenters are from Hungary, Istvan, Dandé, and Magor, Papp. Istvan is the manager of the health service of the Budapest Methodological Center of Social Policy and its institutions. So he manages the health service, which includes a hospital for homeless people and 24-hour health center for homeless people. And Magor works with Istvan in the health service as a general practitioner. So Istvan and Magor, the floor is yours.
Good morning, everyone. Hope you can hear me and hear us. We would like to present our case study from a more practical point of view, from Hungary and specifically from Budapest, from the capital. I would like to share some words about our institutions, which provide mainly social but also health and childcare services in the capital. Altogether, we run 10 hostels with more than 1,500 beds, and also 6 shelters with more than 1,000 beds in the capital, and also 6 day centers. It means that on the average day, it can be said crowded institutions with huge numbers, with sometimes an advantage, but many times, for example, in pandemic situations, many times it's a disadvantage. As Dalma already mentioned, we also have some health services within our institutions in the capital. It includes a hospital, non-stop health centers where family doctors waiting for people experiencing homelessness. And we also have a psychiatric and methodological services here. When we're talking about the vaccination schedule in Hungary, and it was really interesting hearing what was the French position. Well, in Hungary, the case is a little bit different. There was 2 main factors regarding the government strategy on vaccination. First of all, there was the strategy stated that which are those workers and clients that should receive COVID vaccination, first of all. And on the other hand, there was and there is a registration process. You can see the Hungarian website for that, which is available for every citizen. But according to the vaccination strategy, at the first stage, healthcare workers was on the highest level on the ladder, but immediately on the second stage it was the clients and workers of social services, which was a key element regarding for those who run any social institution. But I will give some more detail on this. I assume that in many other countries, not only in Europe, but all over in the world, the pandemic first and second waves affected mainly the homes for elderly, also which is a specific residential care institution. And so to say, our luck was that most of our institutions which provide social services for people experiencing homelessness are also enrolled in the Social Act as a residential care institution. Therefore, last year in December, we had the chance to providing data to the governmental office of Budapest on our health workers. And back in January in this year, we also provided data on our clients and on our workers of social services. And now you can see some data on how the first and second round of vaccination happened in our institutions. But as far as I know, all the residential care institutions in Hungary has the same vaccination schedule, which includes not only homes for elderly or shelters and hostels for people experiencing homelessness, but also for psychiatric institutions or for drug addicts institution and so on and so on. So everyone who runs a residential care institution had the chance to providing data and receive vaccination. And in the first round, our institutions, I have to repeat, it means both workers and clients at the same time, we received Pfizer vaccine. We assume because of these special storing conditions. So everyone was provided to us, vaccines, doctors, assistants, all the equipment. We simply had to organize the vaccination process. And in the first round, which happened just in the end of January, we could provide vaccination for more than 1,000 clients and 334 workers, excluding our healthcare workers. They received vaccination much earlier. And at the first stage, we had the picture that the vaccination take-up rate was significantly lower in shelters. And it was much, much higher in temporary hostels. Altogether, the average was 55%. I don't know if it's much or less, or is it enough or not, but that was the case at the first round. The take-up rate was a bit more than 80% among our workers. And the second round, 3 weeks later, it was in February. And we experienced that, but I have to add that our social workers had to make some enormous efforts that my colleague will also have some words to find 3 weeks later our clients, especially in shelters. But fortunately, the take-up rate amongst others who received the first vaccine and were waiting for the second vaccination was nearly 100%. As you can see in the last row, it was 95%, which we evaluated very good results. Meanwhile, in the middle of February, we had the second chance to register all those workers and clients as well who didn't receive or who were not able to apply for vaccination. And in the second round, we received Moderna vaccines that was delivered into our hospital. And we have to organize the vaccination among all our institutions in the capital. So we were able to provide vaccination further, more than 200 clients and 65 workers. Therefore, the take-up rate in our institutions increased to 65%. We have to regularly report towards the capital, and I've just checked the numbers from the last week and this week. And while earlier we regularly has 15 or 20 or more than 30 clients who were in hospital because of COVID-19. Today we have only one. Which we evaluate again a very, very serious and good result. Well, at the moment, we of course some opening questions because as you remember, according to for example, the French vaccination schedule, at the moment, the Hungarian strategy targeted only for those who are in the residential care institutions. And at the moment, we don't know what will happen with those people experiencing homelessness who are far away from our institutions. There's still a good question for us. Now I would give the floor to my colleague Magor, because he would like to add some experiences on the immunization and also the organization. Please, Magor.
Thank you. We were really lucky because our local government gave us really high capacity to make PCR tests and also antigen tests. So we had really good condition to make mass testing, and we performed more than 13,000 tests in the last year. So we had a chance to reach every case at the first moment. So we were really lucky. Also before the vaccination, in the first and the second waves, during the first and the second waves. And after this, we had this vaccination campaign, as Istvan told you, and we have now some first experiences with the immunization. In the last 2 months, we have collected blood from workers to check their immunization status, and nearly 200 workers and some of their relatives and joined to this status assessment. And our first impressions about that research, that approximately 80% of the clients have got the vaccination before this blood sampling. Only one of them did not have adequate immunization, and approximately 20% of the clients were pre-infected and not vaccinated yet. Most of them also did have adequate immunization, but their immunoglobulin levels were 10 or 20 times lower. So this is a quite good experience behind the vaccination. And also it's a really good to see that we have really high vaccination rates, 65% between the clients and over 90% between the workers. So this is how it happens that only one person is now in the hospital, and only we have less than 10 case at the moment, active case at the moment. So this is our first experiences about the COVID-19.
Please, Magor.
Yes. About the lesson learned with the Pfizer and the Moderna, we reached nearly 2,000 clients, around 400 workers, and nearly 1,500 clients. And it was a really important experience that we have to be sure about our clients will be available for the second round. So we gave reminder each time, documentation after the first vaccination, and our social workers made reminder also, warnings also before the second round. It's really important to make a reminder 2, 3, or 4 times before the second vaccination, and this is how we could reach the 95% of the clients to the second vaccination. So this is our story at the moment, and we hope that in the next 2-3 weeks we can reach the last 30% of the client to make the vaccination.
Yeah, briefly, these are the Hungarian experiences. Should you have any questions, we are here. Thank you, Dalma. Thank you, everyone.
Thank you.
Yes, thank you so much, Istvan and Magor, for sharing these great results in your vaccination efforts in the residential care institutions, and it's great to see that these efforts result in good outcomes in terms of immunization, and that the fact that you mentioned that you have one person with the COVID in your hospital and less than 10 active cases. And thank you for sharing these important learnings with us. Our next speaker is Marian Ursan from Romania. Marian is the executive director of Carusel Association, which emerged in 2011 out of the need for solidarity and to provide social and medical care for people who are in situations of extreme vulnerability. This is a group of activists and professionals who provide interventions based on harm reduction and on evidence. Marian is also a university lecturer at the Faculty of Sociology and Social Work. Marian, the floor is yours.
I will start my presentation with some information about organizations. We are mainly direct service provider. We work with people that are facing multiple different and multiple vulnerabilities. We are talking about people which in the same
Marian.
time, yes.
Sorry to interrupt, but there's a lot of noise near your microphone.
There's nobody
and can you just speak closer to the microphone?
Okay.
So that we can hear you better.
I will do my best, but there is no noise here.
Thank you.
Okay, so Carusel, we are a service provider. We work with people which in the same time are living on the streets, so they are homeless. They are using there are people who use drugs, they sell sex, they have no ID papers, no medical insurance. They are living with also HIV, hepatitis, TB, and many other medical problems. As I told you, we are a service provider, so we work in the field. We have mobile units. We go in different places, we meet people, we provide them with basic materials that they need for, I don't know, to have a less worse situation. We operate a day center in Vandentorren area, which is considered to be poverty, high poverty neighborhood. We have shower van for the people, and during this time we were unable to operate due to COVID-19. We have a day center also for their children, so they can stay in a safe place, they can eat, they can do some exercises. In the same time, we have a center in the hospital. In Bucharest, we have two main infectious disease hospitals, but because of the COVID and the transformation of the hospital into the COVID hospital, we were unable to keep this center. The mission of the center was to make the people which are ineligible for any kind of care, medical care, to make them eligible for the best medical care according with our Romanian standards. But as I told you, that was closed. In the same time, we operate a night shelter, winter night shelter, but of course, again, because of the logistics, we could not operate it in the last winter. What we did when the epidemic started, well, we continued to work in the outreach program, and we somehow had to adapt the services, taking into account that we had these new challenges. We were able to have tons of disinfectants, provide people with masks, and of course all the other services that we are used to do that. I mean the food, tea, medicine, sleeping bags, gloves, hats, you know. When the vaccination became available in Romania, we had discussions with our other colleagues working for different organizations. So together somehow we advocate for the inclusion of the homeless people as a priority in the vaccination strategy. What we managed to do was to have this group in the second wave for the vaccination. In the first one, we had medical personnel and people working in the social services. So in our case, we had the chance to get the vaccination, to get the vaccine quite early, together with my colleagues in January, February. In the second stage, we have the people experiencing homelessness, together with people that are also facing different medical problems. We had discussions with the national authorities. We had discussions with the Minister of Health itself, and we were sure that it would be included. This group will be included. At the end, yes, it was included. And of course, the stage 3, which is for the general population. What I would like to mention here is about is the fact that it was a big challenge how the things will be organized in order to have the vaccination for the homeless people. I think it's a bit similar with what's going on in other countries. We have a national platform where you as an individual, you can log in and you can introduce some data and make an appointment for yourself or for others. Of course, as you might know, in our case, it was maybe easier for the people that are homeless, but they have somehow access to internet, or they have ID papers, because the system requires you to have ID papers and include some data about yourself there. Well, so that was, let's say easier, but the big challenge was with the people that they were unable to provide any kind of ID paper. So in this case, we have a procedure here, and somehow the merit goes to the city and the social work department of the city. In this moment, for example, you can call the police. They can call the police, and someone can. The police officers are coming, and they just check you, and will give you a paper, a kind of an official paper, which states that yes, this is your name. You have this personal registration number, and your also maybe your last address. So this information are good enough in order to include in the platform the people which need to be vaccinated. The vaccination was organized, as I said, by the city, by the social work department of the city, in the premises of the biggest shelter in Bucharest. Of course, it was important to have the information from below. And I think this is the merit of different organizations who were able to talk with people about the vaccination, the need for vaccination. As you might figure out, comparing with the general population, there is no difference. The people living on the streets have the same, sometimes misinformation about the vaccination, about the vaccines, about the side effects of the vaccines, and many of them are quite reluctant to the idea of getting a vaccine. So all of us, starting with the street level, had to discuss with people about the importance and the need for the vaccination. We had here a good initiative. For example, we know that the internet is full with fake news about the vaccination, and there are no reliable information. In the same time, the public opinion is more or less in in the favor for the vaccination, but we identified a source of good information. I mean, the radios, the radio stations, especially the national ones, and what we did was to distribute, for example, radios with batteries. On one hand, the people can, I don't know, have some music, some news, but at the same time they can get good information about what's going on with the COVID-19 pandemic, with information about the vaccination and so on. In this moment, the procedure is even easier to be. It's easy to make appointments for the people. It's good enough either to go on the platform, as I said, or you can just make a phone call to the call center and you can make appointments for the people. In the case that they have ID papers, so the procedure is even clear. But if they don't have ID papers, then, as I said, the social workers working for the city will call the police and they will come to make the identification for the person. This is the only one reason, and this procedure can be done only by the city in the cooperation with the police. So I'm not talking about here other problems. Okay, I understand this is the police, and we don't mess with them, but this is the way it can be done, the vaccination. What we plan for the next steps is to organize vaccination in our premises. As I told you in the beginning, we have a day center in the Vandentorren area, which is also quite. I mean, there are no other services, especially medical services. We don't even have family medical doctors, for example, in the premises in the neighborhood. So we are thinking, and we had some discussions with the people in charge with the vaccination process in Romania. So we expressed our interest to give our infrastructure in order to organize a vaccination center. I don't think it will be only for the people that are on the streets or drug users or sex workers. I think it can be done also for the general population, people that are living in the neighborhood. We were a few weeks ago, we had a quite important visit. We had the head of the WHO Europe visiting Romania. The invitation was sent by the president of Romania. So in this official visit, the head of the WHO Europe had a visit to our services in the street. We had time to talk about how the things are going on, and we're happy to get, I think, a good, excellent feedback. So this is the story, more or less, with all the details that are available for the moment. Of course, I'm looking for the discussions at the end. Thank you.
Thank you, Marian, for your presentation. Well, unfortunately, the sound wasn't perfect, but we really appreciate your sharing your example of cooperation of different sectors to make sure that your clients have access to the COVID-19 vaccination. And as you mentioned, it was the WHO Europe director also recently praised your work in this area. So congratulations. Our next speaker is Henrik Thyssen from Denmark. Henrik is manager and senior physician in the health team for homeless and the homeless health outreach in Copenhagen City Social Services. And this team also works close cooperation with drug user organizations and with all homeless and drug users, NGOs who need health outreach. Henrik, the floor is yours. Thank you.
Thank you. I will try to share the screen. So I will try to give a short timeline on what we have seen in Copenhagen for the last year, and what we have done in the last 2 months in regard to vaccination and spreading that out to everybody who's in need of vaccination. We started in March 2020 on the 12th of March with the lockdown, and we had prepared a month or so beforehand. So we opened an isolation facility with 8 beds a few days later. And we immediately after also opened a night shelter for street homeless. It was, the isolation facility was upgraded to 30 beds in May, and still we had very few COVID positive over these, in that period. We also had very low access to testing, so at that time. In July, we moved our isolation facility to a new house, a former old age or nursing home, and the possibilities with the possibility to have up to 60 beds at that time. But still, there were very few in the spring and summer of 2020. This is the acute night shelter, and it was used for 3 months by anybody who wanted to use it. And this is our isolation facility. It's an old age home, a nursing home. So every person in isolation would have his own room with the TV and get food, and we would provide addiction treatment and with treating withdrawals for everyone coming in. So in December, things happened very quickly. Within a week or so, we had several shelters hit with the COVID, and we had our isolation facility filled up. We had a lot at that time. We had a huge upgrade in testing, so people were found positive, and a lot of those were not able to isolate themselves in the shelters, because most shelters don't have bath and toilet in the room, so they had to mix with others. So everyone tested positive was sent to the isolation facility, at least for while we were waiting for the PCR tests. So our new, at that time, we also got a new low threshold shelter, a night shelter, and our isolation facility was, we had an increase in staff. Actually, it was like working in a small hospital again. I haven't been inside a hospital as a medical doctor for almost 30 years, and it was like being back in the good old days at that time. Mid-January, our outbreak was fading. Vaccination in Denmark began in the end of December. And this is our new smaller night shelter, which was set up. We have several night shelters in Copenhagen, but this one was just set up to be sure that we didn't leave anybody outside. And this is our the office of the new small hospital we had there. It was quite intense for a month. In the end of January, the outbreak faded away, and immediately after, what happened with the outbreak was that our state level became aware that there was a problem. So the first negotiations on COVID vaccinations was initiated in the beginning of February, and in the mid-February, the first 100 vaccines was released to Copenhagen for the drug users in the central city around our drug consumption rooms, and it was set up in a way so that as a nurse from one of the clinics could have a fast track into the vaccination center whenever she had a person revisited by me who could be vaccinated. So the week after, we had 100 vaccinations in 2 nursing homes. So those were the first. Vaccinations in Denmark was in nursing homes. It was people aged 80 or older. So this group was also the first in our in the homelessness area in Copenhagen that we were vaccinating. And immediately after that, we began to vaccinate in large shelters. And 2 weeks ago, we had our first pop-up vaccine set up in a large NGO here in Copenhagen. So what the outbreak led to was actually, it had a lot of attention from the press. So there was an immediate discussion between the National Board of Health and the regional healthcare system with our city. And when I was asked how to perform the vaccinations best, I said, well, we have a team of nurses and doctors who can respond to that within a day. So we set up a new system to use my team as a vaccination team and do that in the different settings that we have all over the city. So we, as I told, we were vaccinating in special nursing homes and shelters, and now we are, and all of those, in all of those settings, we have vaccinated twice. As we heard from Hungary, we have an almost, we have a more than 90% revaccination rate. The problem is that better functioning homeless also hear a lot of negative talk about vaccines, and we have a higher grade of negativism against vaccines among those people. So in the NGOs, we have started. We are between vaccinations. So every NGO we have contact with have had their first vaccine in the last 2 weeks, and we are waiting for the second vaccine in the beginning and end of in the beginning and middle of May. So the overall Danish provision of vaccines is given from the National Board of Health. So the system is very centralized. They decide how many vaccines will go to the 7 health regions, and the health regions are supposed to provide vaccines following a national plan with 10 different groups. And the group number 5, which is the people with chronic illness, is a group that where we had our population of homeless and drug users put into, but most of those don't have a proper diagnosis of for instance, lung disorders or different infections. So they were supposed to be put into this group 5 as a probable group 5, but only after an initial assessment by an MD. So one of my first tasks was actually to be the one who should assess everybody from long lists with a short description of their physical problems. So what we wanted to do was to put our homeless population into this group, which should be actually be vaccinated right now. But we are a bit behind that schedule. So we will have our patients vaccinated in the mid to end of May and not the beginning of April, as it's said here. That's for the general Danish population. So what the hospital regions do is they decide where the vaccines should go. So they feed into our internal structure in the Copenhagen city. And what we have gotten in the social services is approximately 150 vaccines per week, which will be available, and we decide how to deal with the vaccines and where to set up our vaccine pop-up clinics. So what's done in the beginning is that we have office staff from our social services who makes the appointments with, first of all, then there's the regional hospital service, and then with all the institutions and NGOs that we have contact with. So they do a lot of groundwork, so everything is prepared, and I'm connected with that group, and we have final decisions on which days to make the visits, and we give them some time to actually deliver a list of probable group 5 persons to us. So I will get the list and assess all the persons in that list 1 to 2 days before vaccination. And as it is, I would say that only very, very few might not be assessed as group 5 or possible probable group 5. So when the days come, we deliver the vaccines at specific sites, and everybody is registered via our electronic medical records into the National Vaccine Register. So everybody with a social security number will be registered, and it's if we do not get the person for a second vaccine, that person would be able to get a vaccine in all the vaccination centers in any part of Denmark from that time on. But as I told, almost 95%, 96% of all our first time vaccinated comes back for the second vaccine. And we hear very low rates of side effects. Yeah. So the second vaccine day is mostly set at the when we have the first vaccine day. So everybody will know when we will be back. And I was very it was exciting how it would work with the NGOs, but everybody, since we come in these NGOs, they all they have the setup. They know who are coming to their different centers, and so it's easy for them to actually remind people that we are coming back and they will have the second vaccine. So it's very promising the ways it works. So right now we have delivered approximately 900 vaccines in 1 month, in 1.5 months. All nursing homes for drug users and the large shelter users are vaccinated twice. The NGOs are vaccinated once, and we have been waiting for an executive order allowing us to vaccinate migrant homeless without social security. And that was delivered to us Tuesday last week, and we immediately set on to plan how to vaccinate that group in the NGOs that take care of different migrant groups. So regarding who gets the vaccines, we don't have well, we can look at our own numbers, but the vaccine skepticism is generally very low in Denmark. And we see it as being very, very low in low threshold sites. So the more physically diseased people are as we see them, the more interested they also are in getting a vaccine. And there has been a lot of antipathy against the AstraZeneca vaccine, but we have been vaccinating first with the Pfizer and second with the Moderna vaccine. And actually we have been able to press 11 vaccines out of every vial of Moderna vaccine. So we are quite happy with that. When we come to people who are maybe not in immediate homelessness, but somehow around homeless homeless NGOs who might fall through this vaccination setup. Also, we see more skepticism from those groups, and mostly it's due to what I would call information overload. There's so many myths going on, and the more people are attached to Facebook and things like that, the more they are negative against vaccines. But until now, we have presented a lot of positive stories about people who didn't take the first vaccine, but then came back when we were delivering vaccine number 2 to get their first vaccines because they could see that their other people's in the for instance, the day center they come into, that they actually had very low rates of vaccine problems. So they want to take the first one when we come back. We have talked a lot with the NGOs taking care of migrant groups, and we hear from them that especially the Eastern European migrant groups are negative to vaccines, and especially the Romanian group is negative to being vaccinated and registered as vaccinated. What we would do with the migrant groups is we cannot put them into the national vaccination register, but they will, every one of them will get an international vaccination pass directly from us to carry. So almost everyone comes back for the second vaccine. So a small, a quick pass through some snapshots from our vaccines. This is from one of the days where we planned the first vaccine at all in the beginning in the end of February. And this is staff from the regional health region coming with the Pfizer vaccine, which had to be treated by staff from there, but they came to the nursing homes, and we were delivering the vaccines in a room just beside that, inside the nursing home. So the next step was to get vaccinations to the shelter population, and then we got the Moderna vaccine, and we're able to take care of that. So we just have to get the vaccine delivered in the morning, and then we can continue with vaccination throughout the day. And we have vaccinated up to 110 persons in the same sessions. So this is from one of our largest shelters, where we changed our nursing clinic into a vaccination center that day. And it was everyone was taken in especially and given the vaccination, and we had a system set up where I was sitting in the room just beside that and registering everybody. And people were looked after in the way they were supposed to. This is from the men's home. We were able to vaccinate 2 persons at the same time, so we actually had a turnover rate of vaccinated persons of 1 minute and 45 seconds per person. So it went quite fast. Yeah, this is my little spot in that room, just looking at everybody, that everything is going all right, and registering the person being vaccinated. This is from our street paper, Hus Forbi, which has a large day center where a lot of the salespeople come and get food and socialize, at least until we got the COVID. But here it has been changed into the waiting room, where one of my colleagues will supervise people for 15 minutes until they are safe after the vaccination. And this is our vaccination chain. As you can see here, people get in here and they are registered and vaccinated here. And this is the nurse pulling up the vaccines. And here we are sitting, registering the patients. We are 2 because the vaccination session is very quick, so we need to be able to follow it through and do the vaccination, the registration correctly. So and everybody's happy. It's quite easy and fun to do this kind of work. Normally we do long-term work with people with severe complications of different kinds, but this time it's just getting things done from 1 hour to the next. Thank you.
Thank you very much, Henrik, for this presentation. I think it's important and it's great to see how the government reacted fast to the outbreak and stepped up the efforts to vaccinate homeless people. And thank you very much for the photos. I think it's very motivating for all of us to see the action on photos. So thank you so much. I'm actually quite aware of our time, so I quickly present Austin O'Carroll from Ireland, who cannot be with us today, but he was so nice as to send us a presentation in a video message. So Dr. Austin have founded several initiatives that provide GP services for homeless people, and he was appointed as the clinical lead for the COVID homeless response last year. So I'm going to now share my screen and start his presentation. Okay. Something is not working. Why is that?
Hello, everybody, and my sincere apologies for not being there in person today. I hope things are going well with you in managing the COVID epidemic and also in your vaccination programs. I want to describe exactly how we are managing COVID in Dublin in terms of the vaccination program for homeless people. And in doing this, I'm going to first of all describe the impact of COVID on the homeless population, and then explain how we originally had proposed prioritizing various groups and where homelessness came in that prioritization list. Then I want to explain how we had to fight our corner to ensure homeless people got appropriate prioritization. And once we got the go-ahead, how we finalized the plan to manage vaccination rollout. And then a significant issue for us was the overcoming vaccine hesitancy, and I want to explain that, and then our conclusion after that. So in Dublin, we actually had a very successful campaign in keeping COVID out of the homeless population. This was due to a fantastic effort between the Dublin Regional Homeless Executive and the Health Service Executive here in Ireland, along with the various housing and voluntary agencies and other harm reduction agencies as well, and also the specialised primary care services for homeless people. So in Dublin in January 2021, 5.46% of the general population in Dublin had been infected by COVID. In the homeless, only 2.67% had been infected. So in fact, we had half the rate of infection of the general population. And in Dublin, we also had identified all those people who were medically vulnerable and put them into what we call shielding units. And that, in fact, the prevalence rate in there was extremely low at 0.91%. And we know from published research in Paris, where they had a prevalence rate of 52% amongst the homeless population, that this could have been much worse. So we were really delighted with the success of our operation to keep COVID out of the homeless population. However, this unfortunately had a little rebound effect when it came to the issue of vaccination, because as the time for prioritization was coming up, we realized that homelessness were not seen as a priority because
I'm sorry about this, but I'm just would like to ask if you hear the presentation.
Yes, we do.
Ah, sorry then. I wasn't sure. Okay, I continue. Sorry.
No, there's nothing.
Okay. Okay, so you haven't, sorry about this. So you haven't heard the presentation of Dr. Austin, not at all. Okay, I will do again. Sorry. This doesn't work. Okay, no problem. Sorry about this.
I want to describe exactly how we are managing COVID in Dublin in terms of the vaccination program for homeless people. And in doing this, I'm going to first of all describe the impact of COVID on the homeless population, and then explain how we originally had proposed prioritizing various groups and where homelessness came in that prioritization list. Then I want to explain how we had to fight our corner to ensure homeless people got appropriate prioritization. And once we got the go-ahead, how we finalized the plan to manage vaccination rollout. And then a significant issue for us was the overcoming vaccine hesitancy, and I want to explain that, and then our conclusion after that. So in Dublin, we actually had a very successful campaign in keeping COVID out of the homeless population. This was due to a fantastic effort between the Dublin Regional Homeless Executive and the Health Service Executive here in Ireland, along with the various housing and voluntary agencies and other harm reduction agencies as well, and also the specialised primary care services for homeless people. So in Dublin in January 2021, 5.46% of the general population in Dublin had been infected by COVID. In the homeless, only 2.67% had been infected. So in fact, we had half the rate of infection of the general population. And in Dublin, we also had identified all those people who were medically vulnerable and put them into what we called shielding units. And that, in fact, the prevalence rate in there was extremely low at 0.91%. And we know from published research in Paris, where they had a prevalence rate of 52% amongst the homeless population, that this could have been much worse. So we were really delighted with the success of our operation to keep COVID out of the homeless population. However, this unfortunately had a little rebound effect when it came to the issue of vaccination, because as the time for prioritization was coming up, we realized that homelessness were not seen as a priority because they were seen as having a low infection rate. So this, luckily though, the actual, if I go back to the actual thing, that was January. However, between January and March, things got significantly worse. And that was that while we still managed to contain the virus, with the new variants coming in, the higher transmissibility, we found the rate starts to increase. And particularly if the actual infection got into a shielding unit or any hostel, we found that there was a high likelihood that there would be a number of other people infected. So we had put a lot of work between January and March, isolating people and doing test sweeping to try and identify people, particularly asymptomatic people. We found a higher rate of asymptomatics in this wave since January to March than in previous waves. So even though we had created this impression that we were safe, we were getting worried that in fact, with the new viruses, we were more vulnerable to infection. Clíní Cali did some excellent research up in James's, and even though we've had only 5 deaths in Ireland, and even though we've had very few ICU admissions, she still found that homeless people were 5 times more likely to be admitted to ICU if they were positive, and 8 times more likely to die from COVID-19 than the general population. And we use this data to bring forward to the National Immunisation Advisory Committee, seeking to prioritise homeless people higher up. And that helped that argument by identifying this actual high mortality rate and high admission to ICU rate. So this is the priority list that originally came up from the National Immunisation Advisory Committee. And as you can see, homeless people are actually quite far down. We are down as far as number 8, which is residents of long-term care facilities aged 16 to 64. So that's where homeless people were seen as being grouped. Some facilities would also have come under this other grouping further down, where people aged 16 to 64 living or working in crowded settings. So, however, we had pointed out that homeless people had a high level of chronic disease and morbidity. And we were told that they still would qualify if, for example, they were age 70 or over, they could be vaccinated earlier. And if they were age 16 to 69 with a medical condition that put them at very high risk of severe disease and death, they could qualify under that category. So they could qualify under any of the previous categories if they qualified. So this is where we came to fighting our corner, because we came back and said, well, hold on, this is really difficult, because going into a hospital and vaccinating some people against the virus, and then coming back and vaccinating a few weeks later, another group against the virus, that's going to cause a lot of difficulties in crowded settings, because people will say, why are you getting the vaccine? Why aren't others? And then people who get vaccinated may be less likely to keep to the social distancing, wearing a mask, etc. And that could cause other people to lower their guard as well. We also pointed out the difficulties of homelessness being a mobile population and going in and vaccinating some, then coming back and vaccinating others, and then having to chase the first group for their second vaccine. So it was going to be very complicated role in such an approach with the homeless population. So we had Margaret Fitzgerald from Public Health and Donald Cassidy from the HSE fighting very strongly for us to try and change the approach. And eventually we persuaded them to identify that we would be allowed to identify the hostels where we reckoned most people were at risk. So we have two groups of hostels. One is the shielding units, which, as I told you before, we identified those most medically vulnerable and put them into shielding. So the vast majority of people in there would probably qualify under having a chronic medical condition that puts people at risk. And secondly, we have long-term accommodations, which are generally where people who live in these accommodations tend to be older and tend to have higher chronic morbidity profiles. So we identified these two groups of accommodations, and we asked, could we prioritize to vaccinate these groups first? And then we would roll it out according to the national priority list after to the rest of the homeless population. And there were two advantages to this. One is this would enable us to get to our most medically vulnerable. And unfortunately, we haven't Johnson vaccine yet. And obviously the Johnson vaccine would be extremely suitable for homeless because it's a one-shot vaccine and you don't have to worry about follow-up. But we are hoping to have the Johnson vaccine accredited in the next few weeks. But this allowed us to go ahead with other vaccines such as AstraZeneca and Pfizer and Moderna. So we got the green light to do this, and we were all ready to roll around 3 weeks ago. We were being offered AstraZeneca, and then boom, the whole AstraZeneca crisis emerged. And so, as I said, the different types we have here. The Johnson isn't in place. So we were all ready to roll with Johnson. Literally, it was the Friday before the week we were supposed to start our vaccination that they pulled the AstraZeneca. So we had to go back and wait, like many other people around the world, to see what would happen. And in Ireland, they eventually came back and said AstraZeneca was only to be given to people who were 60 years and over. So next thing, AstraZeneca was off the table. So then we went ahead and said, okay, we went back and says we still need to vaccinate these people. So then they agreed eventually. They agreed and said this is the AstraZeneca virus and saying that only people over 60. So then they agreed that they would give us Pfizer BioNTech. Just to give you some information, apologies that we have in Ireland on AstraZeneca thing, just the risk benefit ratio. A number of you may have seen the data from Cambridge, which shows you the potential risks versus the potential benefits. This is Irish data on the left-hand side, where the risks of clotting events are in yellow, the risks of death from COVID are in red, and the risks of ICU admission from COVID are in green. As can be really clearly seen, people over 60, there's absolutely no argument. I think we were particularly careful in Ireland because I think there's no argument for people from 45 up. But under 45, as you can see, the actual benefits start to become much less and the risks become higher. So anyway, AstraZeneca was off the table, but now we had Pfizer BioNTech. So what we have decided in our plan is we're actually starting to vaccinate next week. We were supposed to be vaccinating today, and but unfortunately there was some last minute hitches and we had to defer it for a week. So we're going to start basically tomorrow week our vaccination. And because it's Pfizer BioNTech, unfortunately it means we can't go to the hostels because it's too complicated in terms of transport. So we have set up a center where we will be basically have 4 to 5 people vaccination at a time. We have basically enough rooms that people come in, and they register, and then there's a waiting area. They go in and get vaccinated, and there's an observation area. We will be having a fleet of buses, which we've got from various people, including the DRHE and various agencies, and actually from the ambulance services. And they will be transporting people from the shielding units and long-term facilities to this place where they'll go in and get vaccinated. When we vaccinate this cohort, we reckon it'll take us 2 weeks. So starting next week, we reckon we will be vaccinated all the shielding units and all the long-term accommodations within 2 weeks. Then our plan is at that stage, we expect Johnson to be approved, and we're very hopeful it'll be approved. And if as we expect Johnson will be approved, it has more or less been indicated to us that this would be available to us because everybody recognizes it is the most appropriate vaccine for vaccinating homeless people. At that stage, we will be allowed to go to the long-term facilities and start to roll out the Janssen vaccine. The other big advantage is that we can actually go to the hostels and vaccinate people on site. And there's a large amount of hostels around Dublin. Transport logistics of bringing people to one site would be very difficult if we did all the hostels. And secondly, in our experience from doing flu vaccination, you get a higher uptake if you arrive at the hostel with the vaccine. We also, with the Johnson vaccine, Safety Net have a mobile health unit, and they'll go out and vaccinate rough sleepers as well. So that is the plan we have at present, and looking forward to starting it tomorrow week. Vaccine hesitancy, though, is a significant worry for us. And we did a survey of a number of facilities just to get a feeling for what would be the hesitancy. And now this survey was done just around the time of the AstraZeneca hitting the top of the news, so it's likely to be biased like that. But the vaccine hesitancy ranged from 0, in other words, some places 100% of clients will take the vaccine, to 91% in some settings. So in other words, in that setting, only 9% of clients would take the vaccine. On average, 45% of residents were not willing to take the vaccine. So that is huge and of significant risk to the whole program, because if we want to get herd immunity, we need to get those figures up. The areas of concern is, these are actually the best way of looking at it, is the fear of side effects, the negative coverage in the newspaper about AstraZeneca in particular. People are worried the product is not tested well or long enough, not enough research. People were uncertain, they need more information, concerned of what is in the vaccines. And a lot of people say they weren't going to take AstraZeneca. Worries about pregnancy and fertility. And some people had the idea that the government were holding information and religious beliefs. So that's the range of things. So we now have a campaign going ahead at the moment. In our experience, if we go back to that slide where the hesitancy ranged from 0 to 91%, in our experience in flu vaccinations, what the biggest single determinant of whether people took up, what was the rate of within a particular hostel, was the enthusiasm of the staff. We know certain organizations who have very enthusiastic staff, and we know we will get close to 100% uptake. And it's because the staff will sell the vaccine enthusiastically. So what we are doing is that we are actually taking a thing of actually training staff in how to promote the vaccine. And the key issue is about giving them the information that they need to answer clients' questions. So we've run a number of webinars for staff, giving them all the key information about the vaccines, how they're made, what are the risks, what are the side effects. You can use them in pregnancy. They don't affect people who are immunologically compromised. They don't affect fertility, etc., etc. So give them all the information. So we've run a lot of webinars around. We also, though, are going around and telling staff to give them simple information, which I'm going to give you, that will help them promote the vaccine. And the key thing is we're telling them, be enthusiastic. You can go to someone and say, will you take a vaccine? You could go and someone says, I recommend you to take a vaccine. You can go and say, come on, get your vaccine. Now, you can say it enthusiastically. You can still be honest. If they say, but what about the side effects? Yes, there are side effects, but they're extremely rare. It is well worth taking because it is a really important vaccine. It saves you from COVID, which is really serious. So the type of information we're giving is we're equipping people with knowledge, equipping with them enthusiasm, and we're also adopting an approach of vaccinating the most willing first. And the reason we're doing this is, if we vaccinate the most willing first, so we'll go into hospital, take the most willing, bring them, get them vaccinated, and then we'll go back to that hostel a few days later. And that's because we expect people to hear those people were vaccinated and actually they did well. So let's go. So we're expecting that sort of message will get through. This is the type of knowledge we're spread telling staff. Homeless people are 5 million times more likely to end up in ICU. They're 8 times more likely to die from COVID-19. Get these stark figures across to homeless people. Vaccine prevent risk of COVID infection by 85 to 95%. They risk the risk of severe infection by 97 to 100%. They prevent the risk of hospitalization by 97 to 100%. They prevent the spread to my family and friends by 90%. They are very serious side effects are very rare. Pfizer is severe allergy only in 2 to 5 million cases, and most do not cause death. Moderna, similar. Some vaccines do cause blood clots, J&J 1 in a million. This is how we also show about AstraZeneca. So your chance in a million of a serious side effects for a 25-year-old, 11 in a million, for a 55 is 4 in a million. Dying is 23 in a million from coronavirus, 800 million for a 55-year-old. Dying due to an accident or injury is 110 in a million in a 25-year-old. It's 180 in a million in a 55-year-old. This chart allows people to evaluate risk and give them an understanding of the various risks. So we're strongly promoting the vaccine to overcome hesitancy. So this vaccine does provide the light at the end of the tunnel. And we really want people to be enthusiastic in spreading this thing, because we think that is the most significant determinant of how successful this vaccination campaign will be. Thank you very much, and I wish you all the best in your own vaccination programs, and look forward to seeing you in person in the near future.
Welcome back. I'm sincerely apologize for the technical difficulty. I hope you heard and saw the presentation of Austin, which I think was really great and had lots of information on how to best organize the vaccine delivery and how to equip staff to help homeless people, to help the take up of vaccines increases. Unfortunately, we have run out of time. So I would like to thank you, all of you, for your great presentation. I believe this has been a very informative session this morning. We don't have time for questions, but I think we do have a lot to take away from this webinar in terms of how to advocate for homeless people to be included in priority groups, and about the organization of the delivery and how to reach homeless people and how to promote proactively and strongly, as Dr. Austin O'Carroll said, vaccines among homelessness staff and clients. So if you have questions, please do get in touch with us. If you have case studies, please do share them with us. We plan to have another round of experience sharing in June, because we find it very important to collect the evidence on how vaccine delivery happens. As we know, there will be future vaccination, and it's really useful to have these evidence collected of what works in reaching homeless people by vaccination. So thank you again for joining us this morning, and apologies again for the technical difficulty. Thank you so much for our great speakers this morning, and as I mentioned, the presentations and the webinar will be online. We will be sharing it with you in a follow-up email. So thank you again for joining us, and have a good day. Bye.
Thank you. Bye.
Thank you. Bye-bye.